Okay. Good afternoon. 3 months old male with a new onset of bulging anterofontanel and sunset eyes was admitted to our hospital with no additional significant clinical history. Transcranial ultrasound Doppler was performed and a large mass in the left lateral ventricle was noted with some blood flow in it. MRI was performed after that in the same day, and we can see an iso-intense mass in the left lateral ventricle with some avid enhancement, a cauliflower shape, and some vessel connecting it to the choroid plexus. In the sagittal T2, we can see a diffuse dilatation of all the ventricles. It leads us to the first question: what is the significance of the finding pointed by the arrow? 1, flow void; 2, bleeding; 3, hypointense mass; 4, obstruction. Okay, the correct answer is flow void, and it's consistent with hydrodynamic CSF flow, and maybe it will help us in diagnosis later on. So when we are dealing with the differential diagnosis of intraventricular masses, so beside the radiologic characteristics of the lesion, it's extremely important to take into account the age of the patient and the exact location of the lesion. And in our case, the lesion is located in the lateral ventricle, so we will see why it's important later on. So if we will see some of the possibilities of the differential diagnosis, the first one is a choroid plexus papilloma. We see it more often in the pediatric population, and the location is the lateral ventricle trigon, and we see like a lobulated cauliflower mass with avid enhancement. The next one is choroid plexus carcinoma, and with the same location, and the characteristics are very similar. Beside that sometimes there is a necrosis inside the lesion, and if there is invasion to the brain parenchyma, so we will see edema as well. But it's important to note that sometimes we cannot distinguish papilloma from carcinoma, and it's only a pathological diagnosis. The next one is a subependymal giant cell astrocytoma. It arises from near the foramen of Monroe, so it's not so similar to our case. It's slow growing, and it's associated with tuberous sclerosis. Ependymoma, you can see the patient on the right, the two images, the CT and the MR, can show some, it's an infratentorial tumor in this case, with some calcifications. And in case it's supratentorial, so usually it's extraventricular. Meningioma, sometimes it's located in the exact location that we saw in our case, in the lateral ventricle trigon. But in this case, from our institute, we see additional lesions in different locations in the cranium, and usually it's in older patients. And metastases, and the lung carcinoma and kidney lesions are the most frequent one that can cause metastasis. But in this case, our patient is too young for that, probably. This is a visual representation of the lesions in relation to their possible locations, the most common locations. If you can see, in our location, the meningioma and choroid plexus papilloma and carcinoma are the most common ones, and in our age group, so it's carcinoma or papilloma. So the second question: based on the age of the patient, location of the lesion, and the imaging characteristic, what is the most probable diagnosis? 1, meningioma; 2, glioblastoma; 3, choroid plexus papilloma or carcinoma; and 4, lymphoma. Okay, So the correct answer is choroid plexus, papilloma, or carcinoma. And C. Back to the case. The child was operated in the same day, and the tumor was partially resected, partially due to massive bleeding. And in the pathology, choroid plexus carcinoma was diagnosed. And here are the images that we saw in the beginning. We didn't have necrosis or edema, so in this case, only the pathology helped us to reach the final diagnosis. Choroid plexus carcinoma had some genetics association to Lee-Forlani syndrome, and it's associated with diffuse hydrocephalus, as we saw, with increased CSF production with no obstruction. And the treatment is total resection. And it leads to the third question. Which statement is true regarding choroid plexus papilloma or choroid plexus carcinoma? One, choroid plexus papilloma will always transform to choroid plexus carcinoma. Two, choroid plexus papilloma or carcinoma in pediatrics are more commonly situated in supratentorial location in opposed to adults. Three, the hydrocephalus in choroid plexus papilloma is obstructive. Four, choroid plexus papilloma is usually graded WHO2. Okay, so the correct answer is 2, as we said. Choroid plexus carcinoma is usually supratentorial in opposed to other lesions in children. And in rare cases, we have it in adults, and it's infratentorial, as you see in the case on the right. So some key points. Consider choroid plexus carcinoma in a child with invasive intraventricular mass. MRI may not distinguish papilloma from carcinoma. Pathology is the key. Non-obstructive hydrocephalus due to massive CSF production, and it's supratentorial in children is more common. Thank you very much.